I don't know Anna well, but let me pull up her bio. But I do know the most important thing on her bio, and it's not anything she did in the past. It's something that she's going to do in the future, and that is she's going to come join us at Tufts University in the Department of Community Health. And Anna has a very a very strong background in both policy and in computational science, and she really works at the intersection of those two fields. She got her PhD in health policy at Harvard with kind of a secondary field of computational science and engineering. And she's currently a postdoctoral researcher at the Center for Applied AI at the University of Chicago at Booth, which is the business school. And before I met Anna, before she came and interviewed here at Tufts, I came across her work, and she's doing some very work that is both very thoughtful and creative, and innovative, and technically very interesting too. And I tell you a little bit about it, but she's going to do a much better job than I could possibly. So I'll yield the floor to her. Thank you, Anna, for making time for us.
Great, thank you, David, for having me, and it's nice to meet all of you. Let me pull my slides up. Okay. All right, it looks like I'm sharing. Let's get started. My talk is less technical today, but I'm happy to get into more technical details as requested. I'm assuming everyone can see my slide. Just let me know if you can't. And I'm happy to take questions as we go. Just so you know, given my screen setup, I won't see things coming in through the chat. So if someone could just let me know that.
So I'll monitor the chat.
Perfect. Okay, perfect. So yeah, as David said, my name's Anna. I'm a postdoc at the University of Chicago Booth Center for Applied AI, and I'm very excited to be starting at Tufts this fall. And so in today's talk, I wanted to sort of zoom out and start big. There's a lot. It's almost impossible these days to look at the news and not see something about how AI is going to change society as we know it. I feel like recently, everything I'm seeing right now is saying that artificial general intelligence, or AGI, is imminent. And this is going to have huge implications for kind of the world as we know it today. I would say, and open to other interpretations, that healthcare today feels like a little bit of a different reality. Healthcare has always been a unique sector. It tends to be slower in tech adoption, like we've seen with digitization. That's because the stakes feel really, really high. So there was this article that I link here in Health Affairs that was starting to look at quantify how many hospitals are actually using AI and prediction models today. And it finds that a little over half, about 65%, of US hospitals say they are using predictive models, and most are coming from their EHR vendor, like Epic and so on. And only a little over half are testing them locally, and less than half are evaluating them for bias. And so there's still a pretty big question, an open question out there about kind of what the impact of these models will be as a whole on daily medical practice. So in thinking about kind of the impact of these clinical prediction models, we're often trying to weigh kind of what are the benefits versus the harms. In terms of benefits, there's a lot of research, right, that shows us that clinical decision makers make mistakes, and not only do they make mistakes, but that those can be predicted by algorithms. And so algorithmic solutions could improve patient targeting and decrease unnecessary testing. There's this really great paper by Mullinathon and Obermeyer that looks at how ED doctors try to decide whether to test for heart attacks in the ED. And what they find is that doctors tend to both over-test low-risk patients and under-test high-risk patients. And so if you could potentially improve that targeting of the testing, the potential gains there are enormous, not only financially, but ultimately in terms of patient health, which is what we care about. So in terms of harms, some of these tools may not work as well as we think, which kind of increases waste and unnecessary spending and a lot of time that people take to build them and integrate them and deploy them in the system. And then lastly, many of these medical algorithms have been shown to perpetuate existing biases and disparities in our healthcare system. So I'm going to be focusing kind of on this last point here today, thinking about ways that the data that we're building these medical algorithms on might be problematic in terms of how well it's going to work for different groups of patients. Okay, so when I am talking about algorithmic bias here, there's a lot of different definitions, but the way I'm thinking about it is that algorithmic bias occurs when the outputs of an algorithm are systematically unfair to certain groups of people, and that if an algorithm scores two people as the same, we believe that it should reflect that they have the same needs, regardless of group membership. Sort of bolded these two words here, unfair and needs, because this is the tricky part. How do we define what's fair? And then how do we actually define what need is in these contexts? And that, I feel like defining those two things tends to be one of the hardest parts of these problems, at least when I'm in the research I'm working on. So why does this matter? So if you have algorithmic bias, that could lead to treatment disparities, which could end up perpetuating or even increasing health disparities that exist today. The canonical case here, which I'm assuming a lot of you are familiar with, is the Obermeyer paper that's looking at a pop health algorithm that was used by a health insurer. And they basically found that the algorithm was recommending more white patients for pop health management services than Black patients conditional on health status. And what that meant was that fewer Black patients were being referred to pop health management services. And it's easy to posit that disparities in health conditions that might have been treated via the pop health management services would then sort of remain the same, if not increase, because of this intervention. So what's going on? Why are we seeing this? There's a lot of different potential sources of the bias. One is that's often referred to as label choice bias, is this idea that what we are trying to predict is often not something that's available in the data we have. And so usually you're using some sort of proxy of that ideal target. In the example I just spoke of before, right? They wanted to try to predict who needs additional pop health services, but because you don't have that, definition of need, they ended up using costs of and spending in the healthcare system. And because spending in the healthcare system is potentially correlated with access and use of services, they showed that for two groups with the same underlying health, that they use the healthcare system differently, and that basically created that bias that we were seeing in the last algorithm. There's also measurement bias, so you might see differential missingness of X and Y, and population bias, so differences in training and target populations. There's some other ones in here. I tend to see these three come up more often in thinking about kind of what's contributing to the algorithmic bias we might detect in the algorithms that are being used. So at the heart of these examples is the question of whether health information or other predictive features is selectively observed in the data that we use to develop prediction models. There's multiple reasons we might see this, right? So a patient might be visiting, but their conditions might not be treated or recorded, or patients may not be visiting, and so there's no opportunity to record their health data. So often when we're working with healthcare data to build these models, we often treat 0 as an indicator that something is not present. But really what that 0 encapsulates is both a mixture of something not being present and something not being recorded. And that's going to create a lot of complications when we're trying to develop these algorithms if the level of misrecording differs by groups. So in today's talk, I want to discuss the consequences of differential missing data and potential solutions to it in clinical prediction models. I'm going to focus on two different papers that I'm working on and have worked on. The first one is a working paper where we're looking at the relationship between missing data in the EHR and access to healthcare services. The second one is looking at the relationship between reported family history of health conditions and race. Any questions so far before I dive into the paper? So in the first study, we want to study the relationship between access to healthcare services and EHR data reliability, and then ultimately clinical risk prediction. To do this, we're going to use the All of Us database to study this question. The data includes a lot of different modalities of data, but the ones we're going to focus on are the EHR data and survey data. And the way this database works is basically has participants from all over the country. And when they enroll, they take some measurements and have them fill out a survey. And then they can opt in to basically link their EHR data to this database among participating sites. And so we have both EHR data, so the data that's collected in the EHR, linked with survey data. So we actually have a report of what the patient says, conditions the patient says they have, as well as the access to care, that their self-perceived access to care. So how are we defining access to healthcare here? So the National Academy of Medicine defines it as the timely use of the health services to achieve the best possible outcomes. This is hard to measure, so there's a lot of different factors that are often impact access to care that we end up measuring instead. One is whether someone has health insurance or not. Another might be whether they find their care affordable or not. Availability of appointments, fear and mistrust, as well as inability to take time off from work, child or elder care. And access to care is a big problem in the United States. So about 7% of Americans don't have health insurance. I actually haven't looked this number up recently, so I'm not sure if that's shifted at all in the last few months. And a little under a quarter report being underinsured, i.e. they have insurance, but they don't feel that even with that insurance, they can get the care they need. And there's also large disparities in access to care by race and ethnicity groups. So the sample of data we're going to look at includes about 130,000 All of Us participants with self-reported data on healthcare access and linked EHR data. And we're going to consider two dimensions of access. The first is delayed care, which is whether the participant has indicated that they delayed care for some reason or another. Here in this chart, you can see there's a bunch of questions that relate to delayed care because you had childcare or elderly care, or lived in a rural area and couldn't get there, or transportation, et cetera. And then the second dimension is cost-constrained care. And so that's whether someone has not received care because of cost concerns. Similarly, when someone answers that they didn't have care because follow-up care because of cost concerns or some other thing. So in the survey, you have, I can't remember, like 18 questions that sort of break out into these delayed care and cost-constrained care categories. And in our sample, about 43% of participants indicate that they have delayed care, and 35% that they have not had care because of affordability concerns. And so what we're trying to understand, again, is how access to healthcare impacts the data that we're seeing in the EHR, which we're calling EHR reliability. And so here's just a descriptive graph, which I think is helpful to start thinking about this, which shows that people with cost-constrained or delayed care are less likely to have come in for a medical visit at any point in time. So this is a time to visit Kaplan-Meier curve of sorts. And you can see that yellow line include participants who've indicated lower access, versus that red line are participants who've indicated they have more standard, high access care. And you can see at every point in time along the x-axis, the percent of people within those groups who's come in for a medical visit is lower for the cost-constrained or delayed care. So we're always going to have less visit data available for these lower access groups compared to the high access group.
Anna, this graph is just a toy example, right?
No, this is from the All of Us data.
This is from the All of Us data. Okay, wow. Okay.
Yeah. Yeah, so I think the benchmark time here is just when 2 years before they enrolled. So when you link to the data in All of Us, they basically pull in all of your EHR history and data. And so we can see kind of everything that's happened up to the point of enrollment and after. And this is looking at the 2 years prior to kind of enrollment in All of Us.
I don't want
And just to be clear, that delayed care line is it could be quite socioeconomically heterogeneous. Like it could include people who forego care because of affordability issues, but it could also be, people like me who are on service or people working around the clock in financial services or something.
So it's everyone who's indicated on the Access survey that they filled out at the time of enrollment that they had either delayed or not sought out care because of cost concerns.
Oh, no, but the delayed care was not, it seemed like I can't get time off from work or something. That would
Oh,
also.
yes.
Yeah,
So
so
delayed
that
care.
could be,
Yeah, yeah.
like a hedge fund person who is working around the clock.
True. Yeah, maybe. I haven't broken it out. I don't think we have descriptions that fine grained. But yes, if you've delayed care for a reason like that, they are included here. Even if you split it out though to cost constrained or delayed, we're still seeing that reduction in visit frequency month to month.
Anna, I don't want to go off on too much of a tangent, but I'd be fascinated to hear just a couple of minutes on using the All of Us data, particularly the data that they gather from, these these EHR based interoperability kind of buttons where they just pull in data and stuff, and how complete you found it.
Yeah, it's hard. So it only includes data from participating sites. So we could be missing data in part because maybe someone in the cost constraint and delayed care went to a different hospital, right? That's not a participating site and hasn't shared data with it. And so there's sort of a number of reasons why we're seeing this decrease. It doesn't necessarily mean that they didn't go in to visit. They could have gone to visit somewhere else, but it's just not captured in this All of Us data set. And when we're thinking about prediction, we're going to think about kind of prediction from the standpoint of one of these participating hospitals, right? So like if you're trying to build a clinical model within a specific health system or clinical site, you're also going to be missing this data as well. And so at least from the perspective of the health system that's actually trying to use this data, I think it's still relevant, even if it doesn't mean they necessarily haven't sought care yet. Does that answer your question? I'm happy to talk about this more too.
No, it doesn't. I think that's kind of the, that's the one of the initial things. And I don't know, as you've like kind of looked into the data themselves, I just wanted to share, like, we tried to, we're increasingly interested in trying to get data from participants that we're recruiting outside of Michigan, at the University of Michigan. And when we, so as an experiment, as an example, in patients we recruit within our own institution, we gathered their EHR data through some of these like, APIs that we'll call on.
Got it.
That's so interesting is when we compare it to the gold standard of our own EHR, we don't always get complete data. And I didn't know whether or not All of Us as a group has kind of thought through that, or if they have other ways in which we've, because it has implications, right? Because when we try to compare patients that are recruited within Michigan, the University of Michigan, and we use EHR-based follow-up versus people who are recruited outside and we're using these APIs to call on their electronic health records from like Henry Ford, for example. We don't know whether we're just not, same kind of problem, right? It's like the EHR reliability, but
yeah, and you don't know what you don't know.
We don't know what we don't know for sure. Yeah.
Totally. Yeah, it's a good question. I should look more. It's hard for me to tell exactly how they're pulling data from the participating sites. Like I don't know if it's some sort of API or if they have, I mean, it must be because they're updating the data up to a certain time point every few months or so. but I need to look more into exactly how that process is working, whether it's really like more of the API data that's transferred or actually the data from the system itself.
Thank you.
Okay, so how are we going to sort of think about how access impacts EHR reliability? We're going to compare self-reported rates of health conditions to EHR-reported rates of health conditions. And we're going to focus on conditions that participants say they have, but that we do not see in the EHR data. This is kind of basically assuming that if a participant thinks they have a condition, that they do have a condition. Of course, there's sort of rates of misreport, but we're going to want to try to get a sense of basically how often that mismatch occurs from when a patient says they have something versus whether we see it recorded in the EHR. We're going to calculate the missing EHR diagnosis rate, which is the share of participants with a self-reported condition that have no record of the condition in the EHR. Hate that EHR always updates to her. Apologies for that. And we're going to stratify that by access groups, which includes, again, standard care, delayed care, and cost-constrained care. Okay. The EHR reliability rate is basically the flip of the missing diagnosis rate. So if a high EHR reliability rate here indicates that if someone within a condition, a high percentage of people who said they had a condition, we saw it appeared in the EHR. And what you see is that these red dots, which are representing the two low access groups, tend to be below the blue crosses across almost every condition that we looked at in the self-reported survey. And what that's indicating is that we are seeing lower EHR reliability for these lower access groups. And there's quite a range in EHR reliability overall, which has been well documented, and you can kind of posit why some of these might be much more frequently recorded, like diabetes, versus something like astigmatism might just not be something that's being coded in the specific health systems that are enrolled in the All of Us database. So what are the consequences?
I'm sorry, Anna, can we just go back to that? Because I think I want to make
Yes.
sure everybody understands that. And I think there's a lot of information represented here. So, as we go from left to right, those are the conditions that are much more reliable.
Mm-hmm.
And I guess we also noticed that those are the conditions where are we supposed to be in terms of the blue X's and the red and maroon dots? It's how are
So lower.
so in other words, the X's are right shifted compared to the maroon dots.
Yes, exactly, because within condition,
Right,
there's a higher, and
okay.
so we're really worried. Although again, EHR reliability is a problem
Right.
in general, like we see this huge variation
Yes.
from left to right, as you said. What we're focused on for the purposes of kind of this study is like that.
That gap is
The
so
gap.
it's the horizontal gap that we're concerned about.
Exactly.
Yeah.
So what are the consequences for clinical prediction? So here's an example. So here we see a stronger relationship between obesity and type 2 diabetes incidence among patients with standard care versus delayed or cost-constrained care. And that might just be because the way that obesity might be basically more likely to be mismeasured among this lower access group compared to the standard care group. And so thinking about how the quality of this data that's used in the prediction model might vary by access groups, and ultimately how that would again affect the clinical prediction model for those groups. So here is a model, again, sort of I'm brushing over the details of these the actual predictions themselves, but this is a clinical prediction model we ran in All of Us data to predict 2-year type 2 diabetes incidence. And what you can see is lower predictive performance among those cost-constrained and delayed care groups compared to the standard care. So in this panel, we're plotting AUC, balanced accuracy, and sensitivity. And the black dot, which is the sort of lowest dot on this chart, it's the standard care group. And you can see that among these, that standard care group is higher for each of these metrics compared to the other groups that we've defined. And the 3+ categories here, that's just thinking, instead of thinking of delayed care or cost-constrained care as a binary indicator, there's actually a bunch of questions that they answered. So it's looking at people who answered that basically they had 3 or more questions within the cost-constrained categories that they'd indicated, or 3 or more within the delayed category questionnaire.
What does balanced accuracy mean?
It's just basically saying like a 50% weight towards sensitivity versus specificity. So if it's a rare outcome, accuracy is basically going to overweight your specificity. And so it's just balancing between the two.
Got it. Thank you.
Yeah. We could do different measures here, but we selected these as kind of a balance across the 3. Okay, so before I talk about solutions, I'm going to pivot now to this second study, which is thinking about similar ideas, but in this different context. And so here we want to study the relationship between race and reported family health history and clinical risk prediction. So here we're going to use data from the Southern Community Cohort Study that includes both service. Oh, I see a question. Cornelius, is that correct?
Yeah, I'm sorry to go back to this again. I was just curious. How is it? Is there a reason, or is there a reason why you can be like really confident that a patient is accurate in kind of knowing what they have, as far as a diagnosis or a condition is concerned? As a primary care physician, unfortunately, sometimes patients don't know, or even they don't know that they have a particular condition, or maybe even completely understand the name or how to sort of classify or define or describe like what condition they actually have. So I guess I'm just kind of wondering about like your confidence in the accuracy of the patient report, and then how does that impact the accuracy that you perceive that the EHR, how do you perceive like the accuracy of the EHR given the potential inaccuracies of patient reports?
Yeah, that's a great question. So we are focused on conditions that patients think they have and not conditions that they don't think they have. And so you might expect kind of different rates of misreporting by those. But I think what the issue would be, right, is if we thought that the accuracy of the self-reported condition was lower for people with lower access to care, then we might expect the EHR reliability to be lower for that condition, right? And so that would be a potential source of bias in the results we're seeing, because it would mean that the EHR maybe wasn't unreliable, but that it was just the condition was incorrectly self-reported. And so that's why there's a lower rate there. That's a great point. I think we need to do a better job thinking through which, like from maybe literature, which conditions maybe have better reliability, self-reported reliability, so we can focus on those and exclude maybe some of the ones where we think that's not an issue. I'm not quite sure how to get around figuring out whether misreporting error rates differ by each of those 2 groups, but I agree that that's definitely could be an issue and something that we should think about more.
Yeah, I just think, patients, things like diabetes, absolutely. But, I have to remind some patients that they have CKD, so there's just like.
Yeah. So I think, but if a patient says they have CKD, do you think that is inaccurate?
Yeah, because what you're finding is essentially would only be explained by over-reporting, like patients over.
Yeah. So it's because we're only considering
Yeah.
cases where someone has said that they do have a condition. So it's whether when the issue would be if someone says they have it, but they don't have it. And I don't know, I actually don't, I need to do more of a literature search thinking about how error rates by, basically over versus under reporting. But that I think it's a great point and something that we like very much should dig into more in the paper. So I appreciate the question. All right, shall we move along?
Please.
Okay. Okay, so the second study is looking at the relationship between race and reported family health history and clinical risk prediction. We're going to use data from the Southern Community Cohort Study. Similarly, that includes survey data, which includes personal and family health history, as well as linked cancer registry and death data. And we're going to look specifically at reported family history of colorectal cancer and colorectal cancer incidence. So family health history is a risk factor for many health conditions, including colorectal cancer, breast cancer, cardiovascular disease, and diabetes. As a well-known risk factor, it often results in earlier and more frequent screening. But recorded family health history varies in quality across race groups. So there's been a number of research that's found that family history is better known and documented in white patients. So when input variables and predictive algorithms are less reliably recorded for some race groups, these variables will tend to have less predictive power for those groups. In the example of family health history, the absence of recorded family history may be less reassuring in non-white patients who have been incorrectly recorded as having no family history, either because the clinician did not ask or the patient did not know. So in this study, we're going to look at a sample of about 77,000 adults with no history of colorectal cancer. And you can see in the survey sample, 69% of the sample is self-reported as Black or African American and 31% as white. And we see that Black participants were more likely than white participants to report unknown family history and less likely to report known family history, even though these participants had higher cancer rates. And so this may be suggestive that self-reported family history might be less reliably recorded for Black patients in our sample. Oh, can I go backwards? Sorry. Okay. So as I mentioned before, again, if we're worried that these variables are less reliably recorded for some race groups, these variables will have less predictive power for those groups. Here we saw evidence that self-reported family history might be less reliably recorded for Black participants. And so the hypothesis is that the predictive power of family history for Black patients will be lower than that it is for white patients. So here on this graph, we do in fact see this. So this is looking at 10-year colorectal cancer rates by age, family history, and race. And you can see it's stratified by people who've indicated that they have no family history versus family history. And you can see that basically family history is strongly correlated with risk of colorectal cancer for the white patients, but the line between the family history and no family history in this right plot is basically the same, indicating that basically there's almost no predictive power in the family history variable for these participants. Okay, so to recap kind of from both studies, what we're seeing is that there's a lot of missing data in the data sources that are used for clinical risk prediction, and that this missingness is correlated with groups defined by access in the first example and race in the second example. Again, for the first example, we saw higher rates of missingness for the All of Us participants with cost-constrained or delayed care compared to those reporting standard care. And we also know that there's for the second paper, there is a robust literature documenting differences in reported family history collection for Black patients. And so we see that this missing data could reduce the predictive power of features commonly used in prediction models, And so then, of course, the next question is, how can we address this in the development of clinical prediction models?
Anna, in the second example you gave, I had just a quick question. Was that
Yeah,
a
of course.
study where all patients were universally asked and some just didn't know? Or was it, I think you had in that table, like, was that, because that seemed like a particular cohort that was created, right? Like,
Yeah, so this is part of this cohort. So this is a Southern Community Cohort study. It's located, participants are recruited from in the southeast of the United States. And we're looking at all of the participants who did not have colorectal cancer at baseline. At baseline, they had to fill out this huge, like, sort of family history and health history, and everyone answered this question of whether they had a family history of colorectal cancer, but you were able to say yes, no, or don't know.
okay, so in this case, everybody was asked, and the differences are likely because of just not knowing. Okay.
Yeah, so a potentially different mechanism here than the first example. Okay, so what are the solutions? There's a lot of techniques available to mitigate if we want to think of this as algorithmic bias. So you can pre-process the data, you can change kind of the way you're fitting the model, you could use post-processing techniques. This is just a snapshot of a scoping review I was on, kind of looking through all of the papers on mitigating racial and ethnic bias and advancing health equity and clinical algorithms. You can see there's been kind of an explosion of papers in the last 4 or 5 years. And so it's hard to know, right? Like, what would we do here? What might be a good solution? I mean, ideally, right, we want to ensure all people have access to timely healthcare data. Like, that would fix a lot of these problems, but often, that's not a solution we have available to us currently as we're kind of to develop these models. Another solution could be to collect better data, but that also is expensive and might take time. But there are potentially, like, other sources of data that you could incorporate into these models that might improve them, or ways to, again, like, change the output you're trying to predict. So for these 2 studies, we end up looking at several different approaches. For the study on access, we're going to look at whether adding access as a predictor helps things. So whether you kind of feed that information on healthcare access to the model. Again, that, as I sort of alluded to earlier, access as a variable is not something that is, like, just easily available in a standard clinical prediction model setting. But we're still curious to see whether it would help. And then the second one was including the self-reported data, which, again, we had a lot of the data, and we wanted to see if you added kind of the information from the patient themselves into these clinical prediction models, does that actually improve the models for patients with lower access to care? And then in the second model, second study on family history, we looked at the consequences of adding versus removing race as a predictor in a colorectal risk cancer screening. Okay, so again, for the first model, we're looking at that diabetes. Oh, that's wrong. Not a diabetes cancer model. We're looking at the type 2 diabetes model. And we're evaluating whether adding access or adding self-reported data improves the model. And so it's a little hard to see here. The results are not as kind of profound as we'd hoped. But we do see some small and in some cases significant increases in clinical prediction performance when we added the self-reported data to this diabetes prediction model.
What is the outcome variable that you're
Diabetes
predicting?
in 2 years. So we're predicting on a population who had no recorded diabetes in the EHR. Again, that could include some people who did, but it wasn't recorded. And we're predicting whether they have diabetes recorded at the end of 2 years.
And is that in the all of us data or in the EHR data?
All of us data.
Okay, yeah.
Oh, no, sorry. The outcome is the EHR diabetes label in the all of us data. So there might be some concerns about that outcome label itself. Diabetes is kind of the most reliable self-reported condition that was in the data we had, and the difference between the two groups was fairly small. And so we don't have, so we are using that, but like with the caveat that there are some potential concerns about that outcome itself. Okay, again, so here you can see this forest green dots. Those are the ones that are adding the patient self-reported conditions to the predictor. And again, it's hard to see much in the AUC. Maybe, you know, point estimate moves up, but the confidence intervals are pretty wide. But we're really seeing a lift in terms of sensitivity. So like the share of patients who ultimately have diabetes that are identified by the model. Okay. So this is, sorry, I want to go back. So this kind of suggests potentially, again, that including different sources of data, maybe from the patient themselves, might actually be a really valuable way to improve these models for patients' data who we think might be differentially missing in the EHR or in other sources of data that are being used. Okay, so then for the second model, what we were looking at was whether we should be adding or removing race as a predictor. And sort of I'm premising this paper in a different way than it was published, but really what we were thinking, we started thinking about this in terms of thinking about kind of, are there instances where race adjustments might make sense? There's been a lot of calls to remove race from clinical algorithms. And while the removal of race is often merited, because race adjustments often rely on dubious data, exacerbate health disparities, stem from racially biased beliefs, may be misinterpreted as biological differences between race groups when they're a result of social determinants of health. Again, there's a lot of reasons why we might want to remove these. There's still some question about what the consequences are of removing race adjustments. And so here we're thinking about, in this case that I've sort of set up, how does removing race or adding race to a colorectal cancer predictor change predictive performance for Black patients? And so what we noted was that the colorectal risk algorithm without race underpredicts risk for Black patients and overpredicts risk for white patients. And so the race adjusted algorithm actually was better calibrated for both groups, and ended up resulting in more Black participants being targeted as high risk when we included the race adjusted algorithm versus the one without risk. And so adding the race variable in allowed the model to basically model the fact that family history and potentially other variables were just not correctly capturing risk of colorectal cancer for those patients. Okay, so to recap, when data are differentially missing for patient groups, there's several potential possible solutions that may improve clinical prediction models. You might want to try adding a label for that patient group if it's measured, or adding new data like self-reported data to improve the prediction signal of these models. Preliminary analyses suggest that these solutions could potentially increase resources towards the groups with missing data. But I do think there's this larger question, right, which I'm not going to have the answer for you today, is how this actually translates to patients after deployment. So again, in the colorectal cancer example, we know that using a race adjustment algorithm flagged more Black patients as high risk, which could potentially, right, ultimately flag more patients for screening for colorectal cancer. But we don't actually know how that ultimately translates to screening rates and patient outcomes. And I think I sort of, in this literature and, you know, in these papers, which are mine, there is something mildly unsatisfying about not being able to like look at the results post-deployment. And there's been a lot of interesting research about how the AI-human interaction and how it might not be optimal, right? Like ideally, here's a grid of kind of what the doctor might recommend and what kind of this little AI bot would recommend, and whether the two are incorrect or correct. And what you want, right, is that if the doctor is incorrect, the AI's recommendation can like move the answer into the right direction. Whereas if the human is correct and the AI is wrong, the human knows how to override that. But we actually don't know kind of how that interplay is working all the time. And so it's hard to know when we kind of put these solutions into build these hopeful solutions into these models, what that actually means downstream for health disparities and health outcomes. And so this is kind of an area of research I'm very interested and excited about, and I think is important to be studying more of. And I just wanted to give a flag to governance. This is Duke's ABCDS life cycle. I think in terms of when we start thinking about these post-deployment outcomes, it's really important that we have governance to provide the processes and systems for evaluating these biases and sort of being able to document kind of what it means downstream. And so excited to see more work from this group and others and thinking about those post-deployment outcomes. All right, I'll stop there. I think, yeah, 10 minutes per question. That sounds great.
Yeah, great. Thank you for that talk. Perfectly timed too. Very clear. Anybody have questions for Anna? You know, I'm very happy to get things started. So, you know, I find this work really interesting and really important. I found, you know, both of the problems I think are really important, but I want to focus on the first problem because that's kind of a, you know, you know, it's a new idea to me at least. And it seems like, you know, what you're describing is essentially it's like a label bias problem, where what we want to predict is the risk of developing disease. But what we get to predict is, well, we think the risk of getting a diagnosis, but it's actually the risk of getting a properly documented diagnosis in your EHR, right? So when we use the EHR for risk prediction, so in those populations, we that are kind of underserved, or there's less of a density of visits, or documentation in the EHR isn't as good, we're systematically underrepresenting risk. And it seems, you know, often what we find is that the underserved are often high risk for many outcomes. If you look at some underserved groups, they'll be at higher risk for diabetes, or at higher risk for colon cancer, or at higher risk for lung cancer. But it sounds like what you're saying is that we might be even underestimating the disparity of risk because we're not accounting for the difference in access between those groups. So these groups that we think of as higher risk because they're underserved might be even more higher risk than they actually are. Is that, did I summarize that correctly?
Yeah. So we kind of use, right, like healthcare service data basically to conveniently sort of try to capture health conditions. But if you're really just observing the documented presence of a condition and not necessarily like the condition itself, whether the condition is actually present or not. And so, yeah, it depends again on like what those, if you think the ones are right, but the zeros might be mismeasured, then you really are basically underestimating risk for those groups.
Especially the underserved. And sometimes, often we find that despite that fact, the underserved are often at higher risk for these outcomes. At least that's often the way it works, but maybe that disparity is in risk is even greater. You know, and then, you know, I'm wondering if that's a label bias problem, if we actually don't want to predict the risk of receiving a diagnosis. We actually want to predict the risk of a disease. I don't know. What do you think about the idea that what we want to predict for patients who are underserved is their counterfactual risk of what their risk would have been if they had, full access to care.
Yeah, I mean, I think that would be ideally, right, the best comparator, right? You think that, as you said, like there's label bias. And so if you were able to fix that Y, or, a corrupted Y or X outcome label, then I do, and you wanted to basically assume everyone had the same type of access to care, then you would want to find that counterfactual, assuming under access to care.
Yeah.
I think that
But
makes
it
sense.
didn't, you were using access in a different way than that. Am I correct? Or did you use it in a way to?
I'm using patient-reported
Because
indications
you're
that
still
they've,
predicting the same label, the EHR label,
yes.
which doesn't account for access, but,
I'm thinking if you were a health system and you were just going to roll out this prediction model with the data you had, and we had underlying labels of access to care, basically how that model would perform on someone who isn't accessing the healthcare system to the extent that they think they should be, basically.
And I had a quick question for you. It's interesting, the two data sets you used. Even NIH All of Us, I imagine that the people who enroll in it are going to be different. And I'm just curious how you think that bias plays into this. And have you looked at this or tried to look at this in other ways? I'm just throwing out there, like, assuming that somebody who's like more poorly insured might have some of the same challenges, and just looked in the EHR under other structural measures, and just wondering
Yeah,
what.
that's a great comment. And I thought about kind of adding in those other dimensions like insurance or other barriers to access that are more typically measured. And All of Us is definitely like a selected sample. And so there are kind of issues in generalizing, again, the exact results we see to a larger population. But I think that's a great point and something we should consider in the next version. Again, this is a working paper, and so these comments are super helpful for thinking about how to improve it. I'm not sure how to exactly get around the external validity issue with the All of Us data.
Who tends to volunteer for All of Us? I mean, are you getting the uninsured and the underinsured?
So
also?
those groups are not, I don't know actually exactly how they're doing their sampling, but they're trying to recruit from populations that are typically underserved. So we're going to be overrepresenting those groups in this data compared to maybe a yeah,
A
to
random
the sort of a fair sample of US
Hey, David, could I
or a
ask
random sample.
one other question too? I just want to get Anna's thoughts on this, which is, why weren't the results as impressive as you would imagine? Like,
Yeah, always. It's a good question. I think so. We have a lot. I mean, this is self-reported access, right? And so we did do kind of the most simple way of just saying if you basically had responded to one, or we looked at up to 3, that we considered you lower access. But I do think some of those questions are pretty. I think there's some might be small, like, oh, I didn't pick up a fill, not a fill, but like, I think we can connect those access questions better to the outcome we're predicting, because I don't think they might necessarily translate to missing data in the exact prediction task we're looking at, if that makes sense. Sorry, that's not a very well-formed thought, but I also think it's a lot of people are under accessing the healthcare system. So it's a very large share of the sample we're looking at. And I'm just not sure that the definition of low access that we're using is not like severe enough, but I think might be like more common and less severe again than we might imagine when we were creating the variable. But I'm curious as to your thoughts as well. I've been thinking about whether I should have several definitions of how we're defining that, to think more about that question.
Well, I'm just gonna dump you on this with like a minute left, but like, the Obermeyer paper was like huge, and I saw he's like a colleague, mentor of yours, and what strikes me about it is that without good solutions, I worry that like we're just gonna end up not giving anything to anybody.
Yeah,
And that's a real issue. And I don't know what it means. David has convinced me in a lot of ways with his like kind of classic work that sometimes it depends on what you're using the model for, right? If you're using the model to put somebody in prison, then you want to make sure that there's nothing that's there. But if you're using the model to give somebody a statin, I don't know, maybe, like biases in one direction or another don't matter as much, but it's a huge issue, but like without a solution,
Yeah,
it's such a big problem. I don't know.
yeah, I could
right,
just
right. Like, are
summarize.
we saying don't deploy this if we don't have a solution? No, not necessarily. I think so. I think that's a good point. Sorry, David, I cut you off.
Oh, no, not at all. I don't know if this is what Brahmish was getting at, but if you think about things from the patient's perspective, there are certain shared decision-making contexts where the thing they want is the most accurate prediction. And except in some very niche or boutique circumstances, using all the information available is going to give you a better prediction than leaving information out. There are some boutique circumstances that's not the case. But when you're when you're using the predictions to make what we call polar decisions, then, it seems there's some context where it would actually be illegal, not only unethical, but illegal to include, protected characteristics in the model.
Well, thank you for coming. I appreciate it. Yeah.
Thank you for having me. And I sorry, I see a question in the chat and I don't think I have time for it, but this was super helpful and so great to talk with you all.
So, yeah,
And
this is
thank
Larry's
you.
question.
Larry, I'm sorry. Coding.
Yeah, I do have to jump off.
I agree. I will need to think about that more, Larry, but I appreciate the question. And
Yeah,
I think it's a really important one.
Yeah,
I also have the participating site codes, and I think we need to do a little more thinking about variation by site.
diagnostic coding is a quagmire.
Totally.
So I think when you start to use it to predict important outcomes, you're just stepping in the quagmire.
hmm
And we don't have a great solution for it, but it should just be something we can think about. That's all.
Right.
Yeah.
I think
Thank
that's a
you.
great comment to end on, Larry. Stepping in the quagmire.
Quagmire.
Yeah.
Perfect. Thank you all. And
Thanks a lot, Anna.
thanks
Thank you,
again
Ann.
for having me. Bye.
Bye.
Thanks, guys.